Okay, welcome back to Southern Voices, the series where I sit down with activists, advocates, and organizers doing the work across the South and Appalachia. I'm your host, Lauren Kari. Today's guest is Dr. Staci Tanouye, a board certified obstetrician gynecologist here in Jacksonville, Florida. She's an expert in gynecology, reproductive and sexual health, and menopause care. Dr. Tanouye trained at Mayo Clinic, and she's now in a private practice here in Jacksonville. But beyond the clinic, as if that's not impressive enough, she's built a significant platform as a medical educator with over 1.4 million followers on TikToks and across her platforms, where she dispels misinformation, answers uncomfortable questions, and promotes body literacy with clarity and compassion. She's been featured in Forbes, Insider, Yahoo, and Today. Dr. Tanouye, welcome. I'm so grateful that you're here with me today.
Thanks, Lauren. Thanks for having me. I'm excited for this conversation.
Yeah, of course. So I would love to kind of give those who aren't as familiar with your work kind of a background on your training, why perhaps you decided to go into OB-GYN, and then we can kind of take it from there.
Sure. I did all of my undergrad and medical school in St. Louis at WashU and St. Louis University, and I didn't have a whole lot of medical role models growing up. My mom was a pharmacist, and so that was about as close as I got to the medicine world. And so I'm the first doctor in my family, but from a very young age, I knew that that's what I wanted to do, and I'm not really sure how or why. I just I knew that's where I wanted to go, and I made it happen. And then when I got to medical school, I just loved everything. I loved everything about medicine, about taking care of patients, about the knowledge that you gain, and just kind of that ability to empower people with that knowledge. And I got led to OBGYN because it really was one of just my favorite rotations. I loved taking care of women. I loved educating women about their bodies because I felt that that was just such a, like, it's just something that people don't talk about. And we don't talk about it on purpose when little girls are growing up. And I really wanted to kind of dispel that. So I loved educating on bodies and the menstrual cycle and anatomy and all that. It was my most favorite thing to study and to learn. And it wasn't work to study and to learn it. I wanted to read about it. And so I knew that that's what I wanted to do. Women are my most favorite, and I should say women and everyone with, uterus, ovaries, vulvas, vaginas are my most favorite people to take care of. They are the best patients. They are the strongest patients. And they just have this resilience that I got energy from. And so I really loved it. Yeah, that's how I went into OBGYN.
Yeah, I'm smiling crazy because hearing you talk about that, I think it's birthing people as a whole and, those people who do have uterus, all of those gynecological parts are so underserved. And you're right, there is such a massive gap in sex education in this country, like you said, on purpose. It's strategic. And they are truly the most driven to get to the bottom of their health. I will say the majority of individuals who present with some type of perhaps hormonal issues that I'm talking with, they've got binders. They know, they've done research, they're up on PubMed getting the ID. They're like, well, what about this research? Like, they really are. And unfortunately, because they've had to be advocates for themselves. But yeah, that's such an incredible story to also learn that you're the first in your family. That's not easy to do. So definitely want to give you your flowers. And this conversation is set within the South. So as you are doing your practice, as you are talking to these people, we are operating in the most restrictive area of the country.
Yeah.
And we often center the conversation around abortion, around restriction, limitation. But, you know, polling and everything like that really says the opposite. Do you have any anecdotal experience with your practice of how people speak about reproductive care and receiving reproductive health care?
I mean, a lot. I think even just beyond what people think of as reproductive health care and abortion care, I mean, it goes back to sex education, right? I very early on in my practice, after moving to the South, I had a young woman come to me in the office and made a new patient appointment with me, and she sat down and she said, I am fine. I feel healthy. And she goes, but I'm going to college in a few months and I know nothing about my body. She says, no one has taught me anything. My schools have not taught me anything. She goes, I need you to tell me about my body and to tell me what I need to know and how I can protect myself. She's like, I don't have a partner. I'm not planning that, but I want to be prepared and knowledgeable and everything. And that just like blew my mind. I was like, this is crazy, like absolutely crazy. And good for her for saying, I need to find someone who I can trust to give me that information. But also sad for her that she couldn't go to someone in her household or, so
Yeah.
it was kind of this moment of like, yeah, people need this. Like we need to be talking online. We need to be verbalizing all this more. People in the South and my patient population, I think I have a very self-selected patient population the longer that I've been here, because I have people who now can find me through other avenues, who have found me or followed me online or learned something and realize that I'm local to them, and they will come to see me solely because of what I discuss and what I talk about. And then even my long patients who were with me before that all happened we've learned how we connect, and then they spread the word, and I get a very self-selected patient population. So I'm very lucky in that aspect, is that I have a lot of like-minded people that come to see me, and a lot of like-minded people who want that knowledge and validation there. So I can't say that my patient population is wholly representative of women in the South, just because I know people seek me out for my specific expertise, but yeah, people in the South, they want to learn more. They know they need to learn more, that they've had a lack of education in a lot of this, and they want that autonomy over their bodies, and they really prize that over everything else. And I feel like most people, oops, hold on. My screensaver is going on. Most people realize that autonomy is the priority, that above all else, that autonomy is what we need to put at the top, regardless of someone's beliefs or religions or XYZ. Bodily autonomy is what it is. And I think most people with uteruses and vulvas and vaginas understand that.
Yeah. Yeah, and it's heartbreaking to hear that as your experience, because not only are you trying to treat the patient in front of you and perhaps facilitate trust as a provider, right? Because it is a very sensitive topic, because they understand that perhaps they're coming in with not as much information as they would want to feel comfortable. And then you're also trying to give a education and health education. So I can only imagine what those conversations and those visits must be like. And, just kind of to talk about how you are practicing in the South, um, I guess really I'm most fascinated about what that actually looks like. I, on my end, look at the legislative and regulatory side of like, you know, are we creating this confusion for providers? What must that be like to
Mhm.
actually administer OB-GYN care in the South, in a state where there's a lot of legislation kind of against you practicing to the fullest extent of your board?
Yeah, I think it's a very interesting place to practice. I should say, like at this point in my career, I don't practice obstetrics anymore. I gave that up years ago to focus on gynecology specifically. And so, and right now, I don't have the as much hardship as some of my OB colleagues do because I think reproductive health care, it doesn't matter if it's a wanted or an unwanted pregnancy, it's all prenatal reproductive health care. And so, whether or not you desire a pregnancy really has no bearing on how we care for people in pregnancy. And so all of these laws that come into play, they affect people with desired pregnancies very, very much. And I think that's what a lot of kind of some of the outside population and outside South doesn't really understand is how much this permeates just every aspect of reproductive care that we do, pregnant versus not pregnant, wanted versus not wanted, across the spectrum. It affects all of our care. And so, especially in the OB world, when all of these kind of when restrictions came down, I think a lot of hospitals and labor and delivery units they really had to put clear policies in place. They had meetings and committees to make sure that they drew out and everyone knew this is what our we are following this way. This is what our policy is going to be. We need what they did and what was acceptable. And most of the OB care, once that clear line was drawn out department to department, I think it was okay. But there's always really hard situations that come into play, and most of the restrictions and laws in Florida have made that very, very difficult.
Yeah, and I think that really underscores such an important point is these laws don't give a lot of room to nuance. And in medical care, that's the name of the game. You're treating the patient in front of you. There's not one defined way of one disease presenting all of the time, right? Like there's so
Right,
much nuance in patient care.
right.
Um, and I would love to kind of hear, when you talk about or talk with patients about their reproductive health care, are you finding yourself talking about the policy and regulation while you're in the room? Or is that something that you are kind of, you know, addressing as needed, a PRN?
No, literally almost every day it comes up in some way, shape, or form because anytime we're talking about contraception, the conversation comes up. I had a patient just the other day who was just like, I want to be sure that I don't get pregnant because I right now the situation where the world that we live in, it's not really safe to be pregnant. I mean, so those comments and those conversations are coming up every single day. Every single time I'm talking, having a contraception conversation, we're talking about the risks of failure of contraception and where we live it's not really safe to have that failure right now, so we have to think ahead. We have to think 5 steps ahead of what would we do because of where we live. And so nearly all contraceptive conversations are coming around to safety of accidental pregnancy or unsafety of accidental pregnancy because of where we live. I mean, it's every single day. So that's why when people don't understand, like, oh, I don't believe this, so I don't have to worry about that, or I'm not planning to get pregnant right now, or I'm done with my pregnancies, I'm done with my reproductive years. It really doesn't matter. It permeates everything. And so this conversation happens constantly.
Yeah.
Um, I mean,
Wow.
literally every day in clinic, I have this comes up in some capacity.
That's incredibly heartbreaking because perhaps those patients under a different set of regulations or a different state government would perhaps be more inclined to start their family or,
Mhm.
to start the process of getting pregnant.
Yeah.
And I think,
I had a patient just this week who told me that she's not ready to have children right now because she does not want to bring children into the world that we live in right now. And that is not an uncommon sentiment that I've heard for starting or for making the decision to start a family. It's heartbreaking.
yeah, it's an incredibly hard decision to be in. And it's something that I would love for those individuals who are more anti-abortion to hear how these regulations that they are proposing, we are in a super trifecta here in the state of Florida. We have a Republican House,
Mhm.
Republican Senate, and Republican governor. So all of that, legislation that ends up getting passed and ends up getting signed in the governor's office, how that impacts those individuals who are more anti-abortion. They want people to have more children. They need to be hearing the conversation around the constraints in which people are deciding to start a family or expanding their family. As we know, the majority of individuals who receive abortion care, perhaps specifically to end a pregnancy, are more than likely already a parent themselves.
Mhm.
So, continuing on with that isn't feasible in this, financial, economic situation right now and from a safety standpoint. So I think that's incredibly heartbreaking that you've now had to become a provider as well as a policy analyst who's
Yeah.
communicating the rules. And
Or just
to kind
I'm constantly reminding people of there is more that we have to think about in terms
yeah.
of contraception and pregnancy prevention and safety. There's a lot more that we have to think about. And
Yeah.
yeah.
That's a really great point. And can you actually just briefly talk about what the 6-week abortion ban means for individuals where they could find out that they're pregnant, or, well after the 6 weeks,
Right.
because of when it starts with your cycle?
Right. So 6 weeks is what we refer to as gestational age, but gestational age is not calculated from the date of conception. Gestational age is calculated from the first day of your last menstrual period. And most people, if they have a very regular cycle, are ovulating 2 weeks after their first day of their last menstrual period. And ovulation happens over one day. And so conception only can happen over about one day. And that happens on average about 2 weeks after your last menstrual period. So when we look at gestational age, we're actually calculating that gestational age to 2 weeks before conception or fertilization. And so when someone says, I am 6 weeks pregnant, technically they've only been pregnant for about 4 weeks. And really, you can only detect pregnancy so early on with, over the counter urine pregnancy tests. So really, those are pretty reliable by the first missed period. And so by 4 weeks gestation, if someone has irregular periods, it could be longer than that. If someone ovulated at a later time, like all of it could change, like actually how pregnant you really are. But truly, if someone is tracking their periods, has regular periods, the earliest that they're going to know that they're pregnant is right around 4-ish weeks gestation, maybe a tiny bit before that, and oftentimes a lot after that. And so if you only know you're pregnant when you miss your period at 4 weeks gestation, that means you have 2 weeks to really figure out what you want, what's going on, what does this pregnancy mean, where am I actually at in pregnancy, all of these things. That is not a lot of time. And again, that's only the people who have regular periods and who are tracking periods, which is not the whole population. And so 6 weeks is a really, really tight space of what we're allowed to do here in Florida. Beyond that 6 weeks, there are some exceptions, but Florida has made those exceptions except very stringent. There is an exception for sexual assault, rape, incest, and human trafficking, but that exception only goes up to 15 weeks. 15 weeks is a very arbitrary gestational age. There's nothing about 15 weeks that medically means anything. It's not at the cusp of a trimester or anything like that. So why 15 weeks? Medicine has no idea. And beyond that, for those instances, it has to have been reported. So there has to be a documented police report, restraining order, some sort of official documentation that it is rape, incest or human trafficking. So that, sorry.
And also, as we know, the majority of individuals who have been sexually assaulted don't pursue further legislative
Two out of three.
legal action. Yeah.
2 out of 3 don't report a sexual assault. So 2/3 of women who are sexually assaulted, if that results in pregnancy, there's already so many deterrents to reporting in general. So 2/3 of women don't report sexual assault. And so we're limiting the gestation, which is arbitrary. And then we're limiting who can actually use that exception if they needed it. And then the last ones are fatal fetal anomalies, which again is only up to the 3rd trimester, which is also crazy because the Florida law does not define trimesters the way medicine does.
Oh, okay.
So if you look at in the Florida statutes, they have the first page is definitions. Third, this is absolutely wild to me. So when we talk about mismatch between medicine and legal policy that non-medical people are writing, in the Florida legislature, by definition, the first trimester is, I wrote it down. It's for fertilization through the end of the 11th week. So 11 weeks and 6 days. Medically, that is not accurate. Medically, we are 0 weeks to the end of the 13th week. So basically up to 14 weeks, 0 to 14, where Florida defines it as 0 to 12. Second trimester, Florida defines up to 24 weeks. And medically, that's also not accurate. It's up to 28 weeks. So the end of the 27th week right there is the end of the second trimester. So 28 weeks starts the 3rd trimester, whereas in the in the legal definition in the Florida state legislature, it is the 24th week defines the 3rd trimester. So again, it makes no sense.
Yeah.
It is not that definition of trimesters is not recognized anywhere in the world of obstetrics or medicine, but that's how our Florida legislature has decided to define their trimesters differently, again, to limit those gestational ages. So when they say that fatal fetal anomalies can choose to have an abortion up to the 3rd trimester, they don't actually mean up to the 3rd trimester. They mean up to the 24th week.
And I think that really is such a great example of regulators, legislators trying to circumvent medical evidence, empirical data. And when you start even in those the subtle differences of no, we're defining it this way, it kind of creates this foundation for your ability to start changing the definitions of things. I have come to know that pregnancy technically, really by ACOG standards, is when a fertilized zygote is on the uterine lining, starts to attach.
Right.
And the way that the conversation for fetal personhood starts the moment of conception, and they're saying it's pregnancy right then. So the conversation and definitions seem like, oh, there's just a little discrepancy. That's the foundation for how we start changing the narrative of fetal personhood and how we start talking about that. So thank you so much for bringing that discrepancy up. It's something I had no idea.
Fetal personhood is a whole nother can of worms of danger that when it comes to legislature intervening into actual medical care and standards. And we saw that happen in Alabama, a year and a half, 2 years ago, when there was a case at the Supreme Court of Alabama where people who had frozen embryos, who had undergone IVF, had frozen embryos that were accidentally destroyed. And so there was a lawsuit over this, and the Alabama Supreme Court decided that frozen embryos are considered children. And they used that term in their ruling, that frozen embryos are quote unquote children. And I think they actually use the term extrauterine child, which, I mean, my living
Ooh,
children,
that makes
extrauterine
me,
children. So they named it a frozen embryo a child, which gave it personhood, which treated it as murder when you destroy an embryo. But with that legislation, IVF completely shut down in the state of Alabama because there's so much nuance that goes into the care of frozen embryos and how that process happens, and how the errors that can happen naturally in that process, the things that can happen with transfer of embryos, with loss of embryos during those processes. There's so much that goes into that IVF clinics across Alabama shut down. They stopped because the way the law read, if any mistake was made, or even not even mistake, if any natural occurrence happened, could an IVF clinic be accused of murder? And it was wild. And that was the moment that, and us as OBGYNs have been saying this for years. Like, we've been saying this since the beginning of the discussions of personhood, that we can't do that. It's going to completely shut down reproductive care. So you say you want to create families, and here is an IVF clinic wanting to help create families, but you write laws that are against what you're trying to do. So all of that doesn't match up in the actual medical care, and it crosses over all of reproductive care. And that's what people, I think, don't understand. And that's why it becomes more and more clear that the agenda is not necessarily anti-abortion. It's control. It is absolute control over what people with a uterus and pregnant people can do with their bodies. They want people to birth, but they want to be able to control how that happens.
yes.
Yeah.
Yeah, I could only imagine the conversations that you're having because of, IVF, family planning, even, outside of the OB conversation with gynecological services. I think, in our previous call and conversations, we talked about how individuals are more likely to consider or following through on more permanent methods of birth control and contraception. Um, I
Yeah.
know you mentioned tubal ligation.
Yep.
I would love for you to kind of talk about, one, what that is,
Yep.
and two, how are you seeing more permanent forms of birth control play out in conversations?
Yeah. So tubal ligation is the form of permanent sterilization for people with tubes and ovaries, so people who can get pregnant. Tubal ligation is a surgical procedure where either a portion of the tube is removed or tied off or blocked in some way, or the entire fallopian tube is removed. So there's no passage. So a ovulated egg cannot ever meet sperm. So there's no connection. There can't be a connection to a meeting point there. This can be done at the time of a C-section. If someone is having a C-section and knows that they want permanent sterilization and doesn't want any more children, or it can be done as a separate procedure, like what we call a laparoscopic procedure. So small incisions on the abdomen, putting a camera in the belly button, and using laparoscopic tools to either remove tubes or block or tie them off. And that's considered permanent. It's considered, there are obviously very technical ways that things can be reversed, but the reversal rates are not great, and those reversals are very expensive to do. So while technically possible, not really logistically feasible for a large portion of people. So that a tubal ligation is permanent sterilization for people who could get pregnant.
Got it. And are you seeing more individuals, probably in the last 3 years,
Yeah.
considering these options? Are you like seeing a difference in conversation between a birth control pill or, some form of that type of contraception versus permanent, or is it kind of the same as of right now?
No, after, especially right after Roe v. Wade was overturned, there was a significant uptick of people coming in requesting tubal ligations. There was a significant uptick in young people, in people without children coming in requesting tubal ligations. And so we saw it in our practice. We saw the actual numbers in our practice, and it's been studied. And there was a large study a couple of years ago, I think in JAMA, that looked at those numbers. And in the, I think 2 years after Roe was overturned, tubal ligations nearly doubled in rate of doing them. And those increases in tubal ligations that were done were greatest in the restricted states. So in states that were protected, that had protected laws, there was a small increase. Whereas in states like Florida, where there was a near total or near total bans, rates nearly doubled. And so it has panned out in the numbers, and it's real. More people are requesting that. And I think it's a fine choice for people who want to do it, but we have to realize for people who are not having a tubal ligation at C-section, this is a surgery. This is an actual full general anesthesia, enter the abdomen surgery. So it's a procedure that's not without risk. So it's a big consideration.
Yeah, it's one thing to make that decision from a place of empowerment and understanding your reasoning behind it. And it's a completely different position to be in when you feel like that could perhaps change your quality of life or allow
It's
you
fear
a
driven.
healthy life. Yeah,
Right.
exactly.
Yeah, a decision based out of fear is very different from a decision based out of empowerment.
Wow, yeah, that's incredible. I am definitely going to be looking up that JAMA article. So kind of pivoting a little bit from you practicing here in the South to what motivated you to really start and create an online presence. I'm always fascinated when people make that jump from kind of that expertise and, to then turn to a place of visibility where they are starting to use that expertise, that credentialing, in order to inform the masses, understanding that jump.
Yeah, I mean, for me, it was totally by accident. Like, it was not at all intentional. And I started social media back in 2019 when it wasn't necessarily as, I don't know, it wasn't necessarily a job like some people consider it today. And so I got on social media because at the time I was transitioning my practice. I was transitioning to a separate practice. I was transitioning to practicing GYN only. And I was trying to just kind of locally advertise myself and build a patient population. And I realized very, very quickly that that is not what social media does. It's not necessarily great for local advertising. It is really great for massive education. And so the reach of what I was talking about was far greater than our local Jacksonville area. And so I learned very, very quickly what my audience wanted to know about, what they wanted to learn about, and what was really needed out there, which, I mean, sex anatomy and women's bodies, like, people need to learn about that. And it was a very much desired topic. And so everything I talked about was something new and needed and wanted in that space. And really that just grew into something that I really never thought was possible. And of course, through all of this, COVID happened and elections happened. And that during this time is when reproductive rights is starting to become a hotter and hotter topic. And when you're getting a lot of misinformation from non-medical people, either online or on the news or wherever it may be, who are the people who are reliable and who intimately understand these topics? And how can we get that good information and the factual information out to a massive population? So certainly around kind of these different election times is when that conversation for me online got to be much, much bigger. and the realization that it was really needed, that someone has to be talking about the facts, that someone has to be dispelling the myths. I yeah.
I really applaud that because it is very easy to just say, well, someone needs to be doing it, but for you to then also be like, well, why not me? And to
Mhm.
then use your platform. And I will say it is very common for providers, especially in the world of private practice, to create their own social media. That's actually how a lot of patients are finding providers nowadays. I know individuals who are still inside the Mayo network, so salaried, they're not contingent on finding patients or getting their own name out there, who are doing that themselves and
Yep.
having people come from those avenues as well. So social media is being used in so many ways of understanding information, learning, but then also seeking actual care.
Yeah.
So I love that you had that follow through piece where it's like, you know what? I will, start speaking to this and start informing the audience. And, to kind of go off the misinformation, to me, misinformation is, someone who worked COVID response. I mean, the amount of information that's has no empirical data, no evidence behind it, is just confidently said on a one-to-one screen, I think is profound. When you
Yeah.
start to see it, you see it everywhere.
Right.
Has misinformation online started to impact your patient conversations? Are you seeing that in daily life, or is that more so perhaps just happening on the online world?
Oh no, it's constant. We're constantly. I don't think it's limited to OBGYN either. I think a lot of specialties are seeing this. Pediatrics very much especially.
Yeah.
And we are, as physicians, we are constantly dispelling myths. In my GYN world right now, there's a big conversation about perimenopause and menopause. And there is, so every single day I am dispelling online myths with like literally 50% of my patients. And every single day I'm having patients who are consulting with me who've already seen a different hormonal health provider or done an online hormonal health provider sort of thing, but then came back and questioned what was going on, and then came back and asked me, hey, so I went and did this, but I know I trust you and I really want to get your opinion. And so they're coming back around circle to me, and I'm like dispelling everything that's been happening. And so this is a constant conversation, whether it is menopausal care, reproductive care, vaccination care, vaccines and
Yeah.
pediatric care. We are constantly dispelling myths. And online, again, it's been studied, misinformation spreads faster than truth, because misinformation is sensational, it is clickbaity, it is interesting, it is, triggering, and it's triggering that emotional response. And facts just aren't. Facts are boring. And
Yeah.
so it's been studied. Misinformation travels faster than factual information.
And unfortunately, the rage does increase engagement, but we're also seeing on the other side of the conversation, so the quote unquote pro life, right, that we now know
Mhm.
is it's not pro life.
Right.
Um, the amount of funding that those influencers or perhaps those individuals are receiving in order
Yeah.
to push products that have no FDA or have not been researched or have a sample set of N of 10, or in one study that
Right.
really doesn't say much. So we are seeing a ton of that. And I don't know if you're a fan of The Pit. I love The Pit, but there was
I
a
saw the first
scene.
season. I don't think I've seen the follow-ups, but yeah.
If you have the emotional bandwidth in today's culture and world, go watch the second,
Yeah.
because they have a scene where a pregnant person
I
comes
think
in,
I've seen this scene. Yeah.
presents to the
Yeah.
emergency department having a wild pregnancy, and the information that they had received was like medical intervention and prenatal care is unnecessary, or I think worse, could be harmful to me and my unborn child. I am now showing up with severe seizures and HELP
Mhm.
syndrome.
Yeah.
And so eventually people do seek medical backed care,
Yeah.
board certified care, but unfortunately I don't think as accepted as, or as we're seeing more people seek outside holistic functional whatever that means from providers who I don't know their background training or lack of training, versus immediately going to a board certified practitioner. um, Pivoting with misinformation, I would love to talk about crisis pregnancy centers and the misinformation around those. That is where I had the absolute joy of getting to listen to you speak on that topic. And crisis pregnancy centers are not unique to the South. I know a lot of people assume that. We have it most pervasive, I would say, in this region, but there are these clinics throughout the country. Would you be able to give insight into what these clinics are, what they aren't, and kind of how they operate?
Yeah. So crisis pregnancy centers are these storefront facing centers that make themselves look like they're health clinics. They often will advertise either on billboards or right out front on their signs, pregnant and scared, free pregnancy tests, free, free pregnancy tests, pregnant and scared are the very common ones. So they're trying to draw in people who are pregnant and worried or unsure. And they end up trying to push an agenda of some sort. And so, but all of their facades make it look like they are a health clinic, pregnancy center. They'll use this different wording to make sure that they are following the guidelines, so they cannot be classified as a health clinic of any sort. And because they are not classified as a health clinic, they are not regulated by anything. They're literally just a storefront. They're often run by nonprofit organizations and often nonprofit religious organizations. And then again, they have no regulation because that's all it is, a storefront of a nonprofit. They will often offer free ultrasounds for people, ultrasounds on machines that are 30 years old and run by people who are not ultrasonographers. And their goal is to give people information to encourage them to continue pregnancies and to divert from abortion care. And they will give out information that is deliberately false or misleading. They will talk about free resources for diapers and formula. They will talk about all this stuff to basically encourage and sway people to continue pregnancies. None of them are healthcare providers in any sense of the word. They're usually just volunteers for the nonprofit organization, who are passing out pamphlets and who have done a 1 hour training course of what their goals and what information they're discussing. Most people don't know that they are not health clinics because, again, that's their motive, is to make them present themselves as reliable, as trustworthy, early pregnancy care, to get well-rounded information, and they are not. I remember right before I did that talk in Jacksonville that you were at about the crisis pregnancy centers, I was talking to my mom about where I was going. I said, this is what the talk is about. And I was like, and she goes, she said the same thing. What's a crisis pregnancy center? I'm like, Mom, you know that clinic down on this corner, in this corner, that says, come get a free pregnancy test? I was like, that's not a health clinic. That's a crisis pregnancy center. She's like, what?
Yeah.
So like my 7-year-old mother is like, I thought that was like a legit health clinic that people can go and get a pregnancy test and figure out what they want to do. I'm like, no, it is not. And she had no idea. And the majority of people have no idea. Yeah.
It's incredible to the extent that these organizations go to fooling people that they are providers so far as to wear scrubs.
Hmm.
You
Yeah.
walk in and you believe that you are in a clinic setting. There is a waiting room, exactly like
Yes.
if you were at an outpatient facility. You have different clinic patient rooms. I mean, it really is a stage where they are performing whatever they are doing. And here locally, talking to our clinic defenders, our crisis pregnancy centers have started to reuse ultrasounds because they don't have any, like, you're right, sonographers,
Right.
ultrasound techs. We don't have, they are not in those facilities, or else they would have to start being regulated.
Right.
So what they are doing is reusing the ultrasound pictures and just perhaps changing the name and the date of the pregnant person who is there. And
Yeah.
it's so infuriating because these organizations have titles, as examples, Women's Health Center,
Yeah.
Lifeline Resources, First Coast
Yes.
Women's Services. I
Yep.
mean, those
They use
sound,
services center, um, they to make it sound like it is this clinic, but they can't use the word clinic because you
yeah.
can't. Yeah.
And can you talk about, because they don't have any trained, board certified medical providers actually seeing patients, administering care, could you talk about how this could impact that 6 week ban that we were talking about earlier?
Right. And that's the goal, is to impact that. And so what these centers do is they significantly delay care because a person goes to these centers thinking that that's their care when it's not. And so their goal is to make people wait, make people come back, make people their goal is to stall and to get people beyond the 6 weeks so that it no longer becomes an option where we are. So so abortion care is no longer an option.
Yeah.
That is truly their goal, is to delay care.
Yeah. And I think that's the most crushing part to me, is that an individual could be tracking their period, could be, exactly at 4 weeks, and then go seek an abortion service, like wanting to terminate a pregnancy, and go and are told perhaps, well, you're at 6 weeks. I'm so sorry. When
Yeah,
in fact, the patient themselves are right. They could be at 4 weeks, and
correct.
they're being misinformed and
or
blatantly
or
lied
they'll do an
to.
ultrasound and tell them that they're further along, that then they
Yes.
are knowingly tell them that they're further along, so they automatically think that they don't have any options, so the patient automatically thinks they have no options because they've already bypassed the 6 weeks when in fact they haven't. So they deliberately lie.
Yeah. And unfortunately, I've met one of these volunteers randomly at an
Mhm.
event, and just being like, oh, what do you do? What do? I work in reproductive justice. And she's like, oh, same. Not the same. But I was kind of speaking to her, are you helping these pregnant individuals get Medicaid coverage for prenatal care? Are you helping these individuals then get your child onto the CHIP program, which in Florida, hard to do because we haven't expanded Medicaid yet. So
Right.
you have to be in the system already receiving care, and there's a lot of nuance. But and she's like, well, no, but we, help them get diapers, or maybe we can help them figure
Yeah.
out ways to find formula. So once they kind of coerce these individuals to carry this pregnancy to term and to deliver, God willing that it's healthy, because we know that a lot of these organizations prey on individuals who are under resourced, so
Mhm.
perhaps don't have insurance and
Right.
aren't able to get obstetric care.
Yeah.
um, Seeing that a lot of these individuals then have no resources on the other end of this, and there's no follow through of the patient and this child now. So it really is heartbreaking. In the conversation of what these patients go through that unfortunately end up at a CPC.
Mhm.
When they walk in, are they also told about, we can reverse abortions if you've had one, or how are they communicating with patients about the care that they can offer?
Sometimes they are there is in this in this community there's a big push towards this like reversal pill, this abortion reversal pill, that the idea that if you've already taken the abortion pill mifepristone, that we can give you a pill that will counteract that, so you can change your mind, it's not too late, sort of thing. Mifepristone is essentially an anti-progesterone medication. So you need progesterone to continue an early pregnancy. And mifepristone basically comes in and kind of blocks the progesterone receptors, so the pregnancy doesn't get the needed progesterone that it needs, and so it can't survive. And the idea that there's an anti-abortion pill or abortion reversal pill, basically it's just a large dose of progesterone that they're trying to give people, and saying that, well, you can counteract the anti-progesterone by giving a lot of progesterone. And there is literally no evidence that this works. They will give all kinds of statistics of like, oh, 5 people did this and 3 people are still pregnant, and that proves that it works. And there's a lot of stuff around the internet saying this study when it's not really a study. It's just some anecdotal evidence that was never checked or verified in any way. And yeah, they'll talk about this abortion reversal pill and convince people that that's the right decision to do.
And I think for me, when those individuals show up to a clinic, you're in a vulnerable state. And so when you are trying to make one of the hardest decisions of your life and trying to navigate everything, a lot of different conversations and programming, especially in the South where religion is very, very deep, that programming runs very deep. When you're trying to navigate what you're going to do, and then you have individuals that are further complicating that choice, is what really, I think, drives me to continue to shine a spotlight on these, fake clinics.
Yeah.
And then I think really wrapping up with our conversation with the CPCs is, where are they located? I know you were mentioning like, they're on the corner of like neighborhoods and things like that.
Yeah.
Are you seeing like a trend in the location or because I'm assuming it would be significant for a clinic to pop in on the north side, or, what have you. Do you see any rhyme or reason for that?
I mean, they're very front facing. They're in strip malls. They're on corners like a Walgreens. They're on, they're in locations that are accessible, visible, and look like they could be clinics. Um,
Yeah. And I think too, seeing maybe in areas that are more heavily populated by Black and brown people or
mhm.
immigrants, definitely kind of exploiting the proximity to these
Yeah,
groups of people who, unfortunately, because of systemic failures, lack affordable healthcare coverage to actually seek medical care. They think,
yeah,
okay, I'm in this situation, I'll go to a clinic that in my mind could be like an urgent clinic,
right,
an urgent care.
correct.
So it is extremely heartbreaking to see that. um, I know that we're kind of coming down to our hour, so I would love to touch base on and kind of end it on a positive note. Is how are you finding joy right now? Being in reproductive justice advocacy in the South, it is not for the weak. It is tough, and it is a marathon. So how are you finding joy? What's bringing you joy these days?
Yeah, it's funny. It is not for the weak, and truly, kind of after the last election cycle, I slowed down quite a bit because it takes a big toll. And so over the past kind of year or so, I've really pulled back a lot from social media just to take that time to kind of like take a breath, take care of my family, concentrate on my practice and my patients in front of me. And that has been really refreshing for this time being. And I'm working up kind of the courage to dive back into my audience who is still there and I know still wants the same information. But I pulled back quite a bit because of all of this. And really, truly, what brings me joy these days, especially in practice, is like seeing my real life patients. Like I absolutely adore talking to my patients, and a lot of them have followed me from office to office to office across town that I've seen for a long time. I enjoy catching up with them. I enjoy, they ask me about my family. I ask about their family. I really enjoy our relationships in the clinic, and I love helping them and making sure that they're getting the best information and care possible. It really makes me happy. I was just in clinic yesterday thinking about the same thing. I was like, I really liked that conversation with that patient. Like it was really rewarding to have. And so, yeah, that's still my joy.
I genuinely love hearing that you are still being able to get to know your patients in a world where where providers are constantly being burnt out because
Yeah,
patient interactions are so small, and they've now are wearing a ton of hats, such as educating on sex ed,
yeah,
such as having these policy conversations about how it's going to impact your patient's care
yeah,
and maybe their game plan. It's so easy to see many providers now being burnt out, so to hear
yeah.
that you are still enjoying that aspect
Well,
of
with a
patient
caveat
delivery
of
is
I
wonderful.
often run behind in clinic, and
Sure.
I run behind for many different reasons. One of them is because I love the discussions with my patients. One is because my patient will bring up a hot topic and we'll get on a soapbox. Another is because a patient came in with multiple different problems and I want to fix them all now for them. But the thing is the people who've been with me for a really long time know that I will do that for everyone. So today, maybe they're totally healthy and they just get a quick, yeah, I'm good sort of thing. But they know that the next time when they have a problem, I am taking that time and I'm going to run late for the next patient because I'm with this patient. And so I think all of my patients have had that experience at some one point or another where I've given them the extra time that they needed and then put myself a little bit behind because I knew that they needed that. And so it comes around to everyone.
Yeah.
Everyone's going to get that at some point. But so yeah, I do. I'm routinely about at least 20 minutes behind on a daily basis.
I think we'll do a part two convo at some point where we talk about how we should not be putting physicians as like heroes and providers, because they are people and we do not need to be exploiting their after hours with portal messages. That's going to be maybe my next content creation niche. But no, I genuinely love to hear that you took a step back also from being online. I'm terminally online, and it's definitely difficult. I
It's
recently
a
just
lot.
took a few weeks off to step away in a world where now things happen 24 hours a day, and a lot
Yeah,
of it is strategically created to create rage,
yeah,
not just information and inform. It's so important to step back and to just be like, you know what, I'm just going to be present with the individual in front of me
yeah,
and take care of my corner of the world. And I think that's the beautiful side of advocacy is there are other providers in the area who are also content creation that can also be like, you know what, Dr. Tanouye, enjoy your family, enjoy the summer. I'm still here creating content, and like come back in when you're ready, kind of a deal. And I
right.
think that's the beauty of everything.
And I think there's so many more people, especially physicians and healthcare providers, who are coming into this space, realizing how important it is to have our voices in this space. I know there's a lot of, especially women physicians who will say, oh, but there's so many like OBGYNs already educating online. Like I constantly am seeing all these different ones. I'm like, there is never enough. Like
Yes.
there is literally never enough. And no, you're not copying me when you're covering a topic. We all
Yes.
have to be talking about that topic. Like, send the same message. Please, please, please send the
Yes.
same message that I did and say the same thing. because the more people who are saying good factual information, the wider our reach is going to be. So for physicians in particular, there's never enough of us online. You're never repetitive or copying or anything like that. More people need to be out there who are reliable, trustworthy, have the knowledge to be able to share that knowledge. So
Yeah.
anyone who has expertise, they need to be using it on social media to
Yeah.
educate.
Couldn't agree more. I'm always like, get in the space. We need more people in the
Yeah.
South, in Florida, in wherever, in the nation. Come on in. There's always room. It's very inclusive. All right. Well, Dr. Tanouye, thank you so much for your time and for this conversation. I learned so much today. Links to Dr. Tanouye's social media as well as her website will be included in the written article that will accompany this piece. If this convo resonated with you, please share it or subscribe. And thank you so much for making Southern Voices possible. And we'll see you next time. Thank you, Dr. Tanouye.
Thank you. Thank you so much.